Hello and welcome to our second episode of HCQ TV. I'm Melissa Fox, CEO of Health Consumers Queensland. I would like to acknowledge the traditional owners of the lands on which we're gathered, the Yuggera and Turrbal land. Aboriginal and Torres Strait Islander people have been supporting their community's health and wellbeing for thousands of years and are the oldest continuing culture the world has known. We pay our deepest respects to elders past, present and those yet to come, and we are grateful to be sharing stories and wisdom here today. So today's webcast is being recorded and will be available tomorrow to watch. Tuesday's webcast is now available to view online using the link that you are attending via today. So today we dive deep into a topic that is at the heart of HCQ TV. Co-design and sharing power. Co-design is a practice that health organisations are increasingly expected to aim for, but many staff struggle to understand what it actually means or feel adequately skilled or confident or resourced to do it. Can consumers tell if they're involved in genuine co-design, and what can they do if they believe it's falling short of the mark? And finally, is co-design always the right choice? Today we'll be digging into those questions and more using two co-design projects as examples. The first is what we would describe as a more micro example, a co-design campaign. The Safe in Our Care project from Metro South Health, led by Metro South's Amber Williamson, Senior Engagement Advisor. And Amber is joined by one of the consumers who partnered with her on the project, Phil Carswell. Phil received an OAM for his decades of work in community health and continues to be an active consumer representative. The other example that we'll see today is what we would describe as a macro example. So where models of care, a physical building, programs, resources and more were co-designed, including an adolescent extended treatment facility. Carer representative Vanessa Buiskool had extensive involvement in the project, bringing her lived experience as a carer of a family member with severe and complex mental health concerns, trauma and physical disability. Welcome, Vanessa. And our fourth panel member is HCQ Engagement Advisor Leonie Sanderson, who led the consumer involvement throughout 5 years of the project. So to set the scene, could you give us an overview of the Safe in Our Care project, Amber?
Thanks, Melissa. Well, in 2020, it was a year like no other for everyone. Standard engagement was just not possible. Metro South Health was really believed staying connected with our consumers was vital. And we were lucky to have the actual structures and supports in place and relationships to be able to pivot and turn to actually be able to engage in this COVID new world. We actually partner with over 100 consumers on committees and strategic projects throughout our daily business. And we were able to co-design with these consumers a Safe in Our Care internal communications program. The reason and the problem we were trying to solve, our consumers told us that during this time in the pandemic, early stages of the pandemic, consumers were really concerned about safely accessing healthcare. So a series of engagement activities as part of a plan was developed across the engagement spectrum. And to wrap up all of those activities, we actually held interactive workshops. One was throughout Metro South internally, and another one was with Brisbane South PHN and the Community Council there. Our Metro South workshop was actually an interactive online workshop because everything to do with our engagement had pivoted online and become virtual. Our consumers had done an amazing job switching to online and were much better than staff on many occasions. And what we did at this workshop is we brought together our senior executives of COVID, who informed consumers about all the response planning they'd done in COVID. And then we ran an interactive session using Slido, and consumers rated and ranked priorities of what made them feel safe during COVID and then also came up with solutions. This was all fed into a big report, a Consumer Safe in Our Care report, and that was shared wherever we could share it, we shared it. What our consumers actually said in this report was that the message during COVID the messaging was made for well Australians, and they were providing instructions and rules about the current COVID situation. And what our consumers really desired was an internal healthcare campaign that told them how they'd be safe to access healthcare. A lot of our consumers are those with lived experience. So accessing healthcare never stops. So they wanted to feel safe whilst doing so. If I can go to slide 1, please. So during this healthcare and co-design time, what we actually did is brought our consumers together after that workshop and actually worked really closely with our media and comms team to actually develop and co-design the program Safe in Our Care. What our consumers actually did was table the report with media and comms, and that was their brief. And then they brought back some mocks and examples, and consumers looked at the colours, the designs, the content, the imagery, the photos and the language, and chopped and changed it all and redesigned it. And this is how the Safe in Our Care program was designed. The other thing that was really important from a consumer's point of view was that the material that was developed actually touched and was distributed at key points in the patient journey. So when patients came to our healthcare services, there were elements of fear as they arrived. So the arrival, how safe was that? Their waiting rooms, how safe was a waiting room when we know how busy they are? And so all of the campaign materials were designed in accordance to what patients actually ranked as their biggest fear points throughout the hospitals and health services. If I can go to slide 2, please. The PA was one of our biggest consumer hubs, and we tabled the Safe in Our Care report at every committee we could. And Phil Carswell, our wonderful consumer who partnered with us along the way of this whole entire co-design program, not only co-designed in this program, but he was also appointed at the PA EOC and the incident management team, which were making daily decisions about COVID. And I'd like to hand over to Phil in a second for him to talk to you through more about that voice at that table and how vitally important that was as part of this whole co-design program and where it ended up. Phil tabled our report at the PA, and we were able to implement a program at the PA where we had actually signage changed over internally. So we had signage changed at lift points, we had signage changed at car point entry points, at greeting areas where consumers and community members came into the hospital at entry points, at high traffic areas where people were getting food in the hospital system, and we're at the waiting room where they actually hadn't realised that we had staggered appointments and got to actually transferred a lot of our appointments to virtual care. What we've done as a healthcare system is done all this amazing planning but have forgot to tell everyone. And what the consumers, this co-design program allowed us to do was to communicate that out. So ultimately the outcome was a program that was co-designed by consumers that allowed all of our partners to partner together, share power, and actually deliver a successful campaign that reassured the community that it was safe to come to hospitals and healthcare. Phil, can I hand over to you to talk a little bit more about your experience during this process?
Sure, thanks Amber. I've just had a kidney transplant, so I needed to be a regular visitor to the hospital at the PA. And I was hearing in the queues out the front while people were trying to get in, a steady rise of frustration and anxiety and in some cases resentment and so on. At the same time, in the mass media we were seeing those horrible images from northern Italy where whole villages were under siege and people were getting very, very sick and dying very fast. So it seemed to me that people were saying, I normally go to hospital to get better, but now hospital is where the COVID is, so I don't want to go there. And luckily, because I was on the emergency management team, thanks to previous advocacy from Health Consumers Queensland, when I raised that issue around the table, the senior execs who had been worried about staffing ratios and filling in gaps and finding beds and managing flows in ED hadn't had the human element included in their discussions. They were still worried about, well, and rightly so, about logistics and you know, where can we get more beds from? Where can we get more supplies from? What about PPE? And so when it came time for me to table this report, the really important thing for me was that they actually recognised that this campaign would add value, significant, authentic value to their efforts, and that not only gave the campaign their endorsement, but it also meant that me as a consumer was more credible because I was actually doing things that helped them. And they could see that because there was a natural reluctance by some senior physicians, to treat consumers as vessels to have knowledge poured into. They don't expect to have them coming back and saying, well, no, how about we think about this? And I think that change in the power dynamic is incredibly important, incredibly hard for both sides, but in the end yields a better product for both.
Excellent. Well, thank you both. You've just encapsulated exactly what this whole series is about, but particular today's episode, so thank you. Now, Leonie, over to you. Your project was a lot longer and more complex than the one we've just heard about, yet you managed to weave very meaningful consumer involvement throughout. Can you and Vanessa tell us a bit about the project?
So the Youth Mental Health Project was, it followed a commission of inquiry, the Barrett Adolescent Centre Commission of Inquiry, where there were some really key statements that had been made about the involvement of consumers, carers, families in the delivery of services and the way that services are developed, which led to this very I guess not complicated, but a very intricate program of work. So that ended up being over 5 years, which was quite amazing. So I think, and I think maybe not to sort of not to say that the Safe in Our Care project is less complicated. I think it's probably around the same level, but I think what this project was different was because we had probably about 15 of those types of projects happening at the same time across the 5 years, as well as various governance mechanisms, trying to make sure that consumers and carers were involved at all levels, a very vocal and active group of consumers who'd been associated with the Barrett Adolescent Centre, which sparked off this work. The project was quite political, so there were a lot of different strands that needed to be brought together and to make sure that consumers and carers were really at the centre of the work, because designing a service from scratch is an amazing opportunity, and we wanted to take full advantage of having consumers and carers right in the heart of doing that. Vanessa was involved right from the very beginning. We were just reflecting on this earlier, that I went back and had a look through some of the early emails from when I first started working on the project in 2016, and Vanessa was really actually right there from the get-go.
Yeah, right from the preliminary model of care. And so at that initial meeting, there was a wide range of people at the meeting, consumers, carers, the architects, psychiatrists, education, all different people right from the start of deciding what is this service going to be. But also, yeah, so like someone said, cast of thousands, it really was. There was every facet, bringing their own experience and knowledge to the project as a whole, and really everyone in those meetings and in all the different projects associated with it had the same outcome in mind of really creating a service and a series of services that were for the better health of Queenslanders, and particularly youth mental health. So that was the common goal that everyone had.
Yeah, absolutely. And both your role, Leonie, and yours as well, Amber, I think of, so Health Consumers Queensland and the engagement advisors within health services, you really act as bridges and translators and, trusted connectors, I think, between the health system and consumers and carers. Amber, could you talk about why the aims of the Safe in Our Care project made co-design a good choice, and how you were able to support that in your role as that bridge?
Sure. Obviously, the aim of our campaign was to really build the trust and assurance that hospital were a safe place to come. Just because COVID hit, as Phil indicated, chronic conditions don't go away. And medical emergencies don't go away, and people have to continue to access healthcare services. By all the interaction and the relationships that we'd built up throughout the time, we'd kept our consumers involved and informed, and consumers were telling us and demanding action. And so co-design was the choice because of that very, very, very reason. Co-design was actually driven by the consumer insight that actually was produced. And so on this occasion, we didn't choose to go co-design at the very infancy of the project. It is actually an end result of a series of engagement activities that ended up in making sure that we co-designed action.
That's really fascinating. Yeah, that's the situation and the process actually led you to that as the best way to engage on that engagement spectrum. That's great. Phil, you are an experienced consumer representative and activist of many decades, which we'll talk about more later. What supports were in place for you that made the difference between this experience and other levels of engagement that you've been involved in?
There were a number. I have to pay credit to Andrew Johnson, who was the local incident management controller, who I gathered you had a chat to and told him that a consumer voice would be useful. He made me feel incredibly welcome around this table, and once the people around the table saw that I was helping to add authentic and substantive contributions to their panic, well, not that they weren't panicking, to their never-ending series of problems and issues, I felt a lot of support around the table. It wasn't just like, oh, what do you think, Phil? Oh, thank you very much. Next. It was actually taken on board and analysed and discussed. And in many cases, because they were senior executives, what I was doing was passing on what I'd heard from staff, where their thoughts hadn't managed to go up the chain, but because I dealt with them personally, I was able to point things out to, because the managers are so busy focusing on their KPIs and what they had to do, that sometimes they lost a bit of contact with the human beings that they manage. Not, I know they do the best they can, but in a complex, rapidly evolving, highly emotional, scary environment, sometimes that can get a bit lost. The other engagements I had in Health Consumers Queensland ran regular Zooms, consumer conversations, and I found the experiences I was having at the PA reflected in a number of other locations. Although it was interesting to me that I think the PA was the only hospital that actually had a consumer on the EOC, Emergency Operations Centre. And I think that really did add some value and depth and perspective that they probably weren't expecting. And it's now led to other engagements. I felt supported in the room. I felt supported by HCQ. I felt supported by Amber and all those other 100 consumers. So it wasn't just little old Phil being cranky again. It was actually, I was part of a team of people who were all feeling the same way. So you can speak with some significant degree of confidence. And pretty soon became clear that the senior management really wanted to hear that. There were times when I could, because they were all employees of Queensland Health, there were some times when there would be a instruction from head office that they would look around the table and say, what the hell is this all about? And because I was a consumer and not bound by Queensland Health's protocols, I was able to call it out as rubbish. And so I wrote an email to, in one particular occasion, I wrote an email to David to say, this idea is stupid, it should be taken out in the back and shot, and a few other things. And he took that to the DG and direct. The DG laughed and tore up the directive. So being independent of the strictures of being a Queensland Health employee meant I could speak much more freely, which they all really appreciated because they were all thinking it. They couldn't say it.
It's a very powerful position to be in, isn't it?
Yes, it is.
Yeah, absolutely. And it really brings to mind, what you had pre-existing relationships with some of these people, and this was an opportunity to deepen relationships, including, as you said, clinicians. That partnership between ourselves and clinicians, we're often on the same page and with the same aims. But Leonie, I'd like to ask you about partnerships and relationships. There were a lot of people involved in the entire project. What were some of the key elements to the success of the relationships?
So I think we had to make relationships. So the situation that had come prior to this project was one of pretty low trust amongst families, young people, with any kind of clinicians, definitely with Queensland Health. So that was something that we were all aware of going into the project. But I think, like Vanessa said, there was this willingness and a vision that everyone wanted to achieve. So everyone entered into those relationships with that attitude that this is something that we want to see this happen. So we're going to hold our ideas and be brave about putting them forward, but also hold them in a way that means that they're open to shifting and changing. I think that was really important. I think taking the time to have those relationships. So the first 12 months of this project were deadline after deadline after deadline because we were working to the cabinet submission timetable. So these things are imposed upon us, and we can't do anything about that. Having said that, we were also aware that sometimes you can't rush things and you can't go for the quick fix. So if we can try and look at things and not have that attitude of like, well, we just need to get this done now, we can take our time and go out and talk to people a bit more about it, then that was, I think, something that was really, really beneficial and useful. There are so many things. I think making sure that things were meaningful for consumers and carers. So being able to not just have them on a governance committee where they are present and that's their only role is to be present, but actually for those consumers and carers to decide how they want to participate in that committee. So with the group that we had, they all spoke to me and said, we don't want to just be there to be keeping a check on what everybody else is going and doing in their parts of the project, and they've all got jobs and they've got, these very defined, discrete things that they're doing. We actually want to contribute too. So we worked really hard to deliver a presentation, to come up with a wish list, to consult with a really broad group of consumers, to do a survey, to come back to the table with very tangible things that the rest of the committee, who were, at a really high level in Queensland Health and Education and Department of Premier and Cabinet, to say, look, this is our contribution and we're not expecting a free ride here. We really want to be part of the decision-making processes. And I think that was really important too.
And I think really shifted. I remember those early meetings and really increased the knowledge of everyone around the table about what everyone was trying to do. It was so important.
And I think made it human, you know. Like, and I think if that's something that consumers and carers bring, is the human experience, and it's really important. It's really important.
Vanessa, similarly to what I asked Phil, what were some of the factors that supported your involvement in the processes Leonie described?
Well, to start with, I can echo what Phil says about being an independent voice in the room that has the freedom to say something that if you were part of a service you might be less inclined to say, so you can speak up. And in terms of support, knowing that with some of the projects, say for myself, knowing that a representative of Health Consumers Queensland was in the room or supporting in other ways, does give a personal sense of security. But the other thing, I guess, is that the way, because it's more than just being in the room, like Leonie was saying, being in the room might be an hour or 2 hours, but it's all the flow on work so they're just the touch points. And so there's a lot of work on everyone's behalf that goes beyond the scene. So that's where you're just crossing paths, exchanging information. And in those exchanges, the way I supported myself was by educating myself of how to be a good carer representative. So knowing how to communicate and gradually over time learning the language that's used and the terms, and also speaking to other people and hearing their stories and experiences. And so a lot of information is gained, and say for our own health journey as a family, by talking to one of the clinicians in, over coffee as these things happen, set our family's health journey in a whole different, we're going this way, we're going that way. And so all this other knowledge that I could educate myself with changed our trajectory. But there was one other thing I was going to say as well. It's also knowing that through the whole projects, it is a level playing field. So whoever you are coming into the room, there isn't a hierarchy, or I wasn't really aware of it. So if I was to contribute to a meeting and my perspective was just as valid as the person sitting next to me, and that is really that's very valuable. Yeah.
And I think sometimes I even heard in those meetings a reminder from Dr. John Wakefield, who was the chair of those committees and really the driver for this co-design process. He would refer back to the consumer and carer representatives for your views on each agenda item and remind everyone that it was, what consumers and carers needed that really needed to be at the heart of the project. That was very powerful.
And in those meetings, I think because of what had previously happened with the previous service, there was a lot of heartbreak, and so people were very worried. So it was a very volatile situation, and it almost seemed hard to believe that there could be a service that was even better. But I'm sure Leonie's going to say a few words later about it, but just. I can't believe it. It really, all those meetings and the hundreds of hours of work people put in, it really has paid off. Yeah.
Yeah, for an incredible service and
Yeah.
facility, absolutely. So just a reminder to everyone online, please do pop your comments and questions in the chat. They'll come through to me and we'll be asking them shortly. Co-design is a term that's gaining traction, as we've talked about. We're seeing it used more and more frequently. Is everything that's labelled co-design actually co-design? And Phil, we know that co-design can be done badly. What are the telltale signs that a project is not true co-design, and what is the cure?
Go, Phil.
Okay, I've got the cure right here. Sell it for $1 million. I think one of the key points that I've noticed, and this happens in lots of areas, the more you use a word, the less value and impact and meaning it has. And so it becomes shorthand, and a lot of people don't understand the shorthand. They think co-design means you talk to a colleague, or you talk to your manager, or you talk to another hospital, or something like that. So rather than saying what co-design is, I know what co-design isn't. And the crucial thing was one of the points that was made earlier about being involved from the very, very beginning. Not being presented with a project plan or a research proposal or a funding submission and saying, okay, we need to have this in 24 hours. Can you please read it and tick it off and say it's fine? Who decides the research questions? Who decides the priorities about care and service provision? Who decides the priorities of where staff go in a hospital, or what services are next in line, or who decides the relationship between the hospital and the community that the hospital serves? And those are questions about power and changing the power dynamic so that it's not automatically assumed that senior clinicians and professors and doctors and some senior clinicians and professors think they've got the authority and the capacity and the mandate to make unilateral decisions or not is just rubbish. And they have to be challenged to say, no, if we're going to have co-design, you've got to give up some of your power. And that is incredibly hard to do because no one gives up power voluntarily. It's usually going to be wrested away from them, or negotiated or arbitrated or some other. I mean, it's not. No one gives away any advantage they have willingly, whether it's the superiority of being the best clinician in the country being spoken back to by some lowly patient who might just know more than they do. Whoops. But it's about acknowledging that there's a power dynamic at play, and co-design means that power is now not so much equally, but it's genuinely shared so that all parties know that their input is not only valuable but adds value and is incorporated seamlessly into the ongoing process. And that's a dynamic process. That's an ever-evolving process. You can have a good meeting where you get agreement on some things one day, come back a fortnight later, and suddenly someone's cracked the SADs and you go right back to base one again and have to argue from first principles. It's never given easily or gladly. So you've got to learn to be resilient, and you've got to learn to be straight down the line with them and consistent and trustworthy. And then eventually that power shift can start to move.
And I think once people in the system have worked in this way, it's very difficult for them to go back because they've seen the benefits.
Yeah.
It has just made, I've never actually reflected on both of the projects we're talking about today, and what the drivers were for, as you say, wresting power from the system. Sadly, the Youth Mental Health Project came out of the tragic deaths of 3 young people. And then, of course, the pandemic with the Safe in in our care project with Metro South. Amber, what would you say to those working in the system to encourage them to not just use this way of working in such heightened times or tragic times such as those? And what would you say to them about why it gives such great results?
Yeah, well, I mean, look, co-design, as Phil and yourself has indicated, it's a circular cycle. It's everyone has a seat at the table with an equal voice, and everyone raises their perspective and brings their perspective to the table. And they're actually, consumers are there every step of the way. And that is very different in terms of this co-design thinking. But the benefits and the results that co-design brings is that it actually, not only this equal voice at the table, it ensures that the services, the campaigns, the new builds that are being developed, the consumer's experience and the needs of the community are actually factored into the decision making. And so ultimately what the outcome is a better outcome for everyone. And this actually also in turn builds community trust in our healthcare system.
Can I add one more quick point? Amber's absolutely right. You've got to have a seat around the table, but you've also got to be heard. The people, you can speak as much as you like, but if people just say, yes, thank you, Phil, next, move on, then the seat isn't enough. You've got to have a voice. And what I found really useful in the EOC and at the time of the COVID epidemic, if I raised a point that needed follow-up, it was added to the action register, and the next meeting we had, there was a result. So it's not like consumer voices were tokenised. We were actually seen and heard and listened to. So it wasn't just a phony exercise. Things were followed up that we raised. And I think that adds an extra layer of credibility to what we're doing. We're not just tokens. We actually deserve to be treated like any other person in that room would be.
That's wonderful. And Amber, that does feed into a question here from David. You talked about the benefits of co-design. Do you think that those you've worked with in the health system would say that co-design saved time or money, that avoided mistakes or wrong direction being taken as a part of the project? And have you seen them become champions of co-design as a result?
Yeah, so your initial response is that co-design just takes too much time. And initially, it can take a lot of time. It can take a lot of the time that I did in my role with this campaign was actually internal championing, internal education, what we were trying to achieve, championing the why in the report rather than the what, because the why was what we wanted to focus on. It was what our consumers and the community needed. And so, ultimately, co-design can save money because the fact that we develop a program that's encompasses everything, encompasses all different walks of thinking, and we should be addressing those needs rather than a governance-driven sort of solution that doesn't necessarily look at the human factors that we've talked about today. So ultimately, co-design in the end can definitely save money and save lives, as in the Barrett example.
It might take time to do the process properly, but it takes much more time to undo mistakes.
Absolutely.
And the other thing as well, we have systems in place to make decisions in healthcare, and often it's governance driven. So we spend a lot of time in meetings and tabling reports and getting decisions made. So actually, if we go to the co-design solution, that actually changes the way in which that we work. So they might not necessarily be tabling those decisions there. it's actually been co-designed because we've got those players at the table.
Yeah.
Absolutely. Leonie, I know that sharing power with consumers was a new concept to many staff of many of the organisations that you were supporting across your project. What did you do behind the scenes to support and encourage staff who may have been cautious, resistant or fearful about co-design?
Good question. I think I think there's an element of coaching that kind of comes into the role, and maybe Amber can relate to this, where you've got to encourage people to, because it is a really new way of thinking. And I'm thinking of this example, just as you were talking then, Amber and Phil, about a cancer service that actually found out that the service that they were providing for people was not it was more focused on the doctors and saving their time rather than saving patients' time. And I think when you start to flip those ideas about, well, what happens if we say that the patient's time is just as valuable as the doctor's time? Or what happens if we say that the people who are coming to this service, that the way they experience it is more valuable than what's important for how the staff process people? If we start to flip those things, we start to shift power anyway. So we start to see the power move. And that can be a little bit scary for people who are working in a really hierarchical system. So we had to really, I guess, show the benefit of how this works, how we build better services, how bringing people along with you builds better relationship, means that what we designed was better. And I think it wasn't even just Queensland Health staff for the Youth Mental Health Project, it was also the architects and the Department of Education, because they hadn't worked in this way either. So the architects came and on several different buildings. So we've built 5 buildings over the course of this time. So when the architects came with their plans, I don't think they were really expecting people to say, no, this is terrible, this is not what we want at all. I think they were expecting something quite different. But once they were able to let go of being defensive, and I think that takes a little bit of time as well, they started to see the possibilities. So I think leadership made a big difference for us in helping people to move and shift power and share power, because leadership said, yep, this is what you have to do, this is the path that we're taking, and we expect a better outcome as a result. So that helped us a lot. But all of those little things kind of feed into it, I think.
That permissive leadership is so vital.
Yes.
Sorry, I didn't mean to interrupt, but there's one other thing too. One of the manifestations of power is remuneration.
Yep.
And having people, consumers, spending hours and hours reviewing documents, going to meetings, looking up issues, researching, talking to peers, finding out what other consumers think, takes time, and our time is valuable, as the clinician's time is, and the governance time is for the managers. So a real symbol of being of power is having those consumers properly recompensed for their not just for their time, but for the value they add and the knowledge they've got, which you can't buy. You can't buy anywhere. So it's really crude, I know. Money equals power. Great insight, Phil. But it's a good manifestation of being taken seriously and being treated with the respect you deserve, because you're getting paid for it. And that gives you an obligation to make sure you keep up with the flow, but by the same token, it also means you're on a much more equal footing around the table.
Absolutely, and we were very fortunate to have funding to remunerate consumers through the Youth Mental Health Project, and it's certainly remuneration of consumers is not consistent across Queensland's hospital and health services, and we're sometimes told that their budgets are constrained, and but we say, well, what is the cost of not remunerating so that that you get those diverse, informed voices of consumers across the system.
And could I just add to what Leonie was saying about is linked to the remuneration as well, but with the when the architects were involved with the project, they were amazed at the fine detail that the consumers and carers were, in particular, were interested in the building. But when you have been a consumer or a carer, you've spent a lot of time in the building, so you've been using the building. So the fine details are very important. You know, it's all about the fine details. So it's a great opportunity to influence from the bricks and mortar. And the remuneration is also about respect. So, and that does level the playing field, because if you're in a room with 30 other people and you're the only one not getting paid, well, your time and effort and knowledge is just as valuable as each other person in the room. So yeah, and it's also, it does take into consideration that a lot of consumer and carer reps have a lot of they have other responsibilities as well, but they may be doing multiple roles. So if there's only so much an individual can be generous with their time, you know, we could all be working 40 hours a day if we could. But it's necessary, isn't it? Yes.
I think Phil has
Phil
probably
does.
done that in his time, absolutely. Now, Amber, your project was all about COVID, and so of course took place under very different circumstances than the other projects you've done in your role. Did COVID allow greater sharing of power? Did approvals happen fast, supporting timely co-design? And did you see a flow-on of the creation of these resources, say, when there was the outbreak earlier this year at the PA and out to other facilities?
Sure. Look, I think Phil is absolute testament to that. So Phil having a seat at the table who was heard and listened to and acted upon in the PA EOC, and you know, that in itself is a demonstration of sharing power. I think for our internal stakeholders with Safe in Our Care, we, as I said, focused on the why, because when we started to focus on the what, that was when we came at a stalemate. But when we took the conversation and the engagement and the conversation back to the why, this is important and what consumers had talked about, it enabled executives to actually share that power because it made sense. So, you know, to answer your question in regards to decision-making processes, well, during COVID, all non-essential committees were sort of stood down because everyone was working in different positions and running around doing different jobs and playing different roles. So therefore, the access to decision makers and key decision makers was, I suppose, less bureaucratic in that sense. And we had access to the Metro South HEOC, which was the ultimate control centre of all the decision making throughout COVID, and then all the different site EOCs as well. One which Phil sat on. So yeah, access to you know, even getting a diary appointment with these executives to have a quick chat was actually easier because of these abolished systems during COVID, and also the regularity in which that people were meeting. Phil, how often were you meeting? And at the early days,
Usually daily.
if not twice a day, I think.
Twice a day when it got really hairy, yeah. And on weekends and late evenings, if there was an outbreak of some sort. But my experience around that table was that the senior executives were actually feeling liberated, because if they wanted to make a decision and cut through a whole lot of red tape, they did it. And the roof didn't fall in, and you know, Jeanette Young didn't come through and yell at them or whatever. They were given the agency and the power to make decisions on the spot, because that's how you fight a virus. And I think a lot of the senior executives around the table actually felt quite unburdened by some of the requirements that were lifted from them. The one area I noticed where there was a problem was when with comms, communications, because there had to be a consistent message from central to all the HHSs to the hospitals. Somehow, if we had a good message at PA, by the time it got to the Metro South EOC and then into town for approval and then back out again, it was 5-6 days later and the epidemic had changed. So that frustration was probably the most tangible problem that we had. But the overwhelming feeling of, we need to do this. Okay, let's do it. And it was done. That just made so many people start to analyse in their mind, why do we do things this way? Why can't we do things in a more efficient and more effective way with the support of our consumers and our governance?
Yeah, and part of the decision-making process with the executive in comms for Safe in Our Care was definitely to focus on this internal program that consumers were asking for, because we had that complete control of that. So therefore the burden and that hierarchical process and signing off, as Phil's talking about, wasn't as necessary, because it was within our, we were talking to the patients that were in our facilities. So, you know, it was kind of working with what had to happen at a federal and state level comms-wise, but what we could actually do within our control.
Absolutely. So there's a question here from Christine for Leonie. How do we evaluate true co-design, and who should evaluate this to avoid bias?
So I guess if we're evaluating whether it's been a true co-design process, that's a really interesting question too. I think so. I don't know that we did that in this project. I think we looked back and we could see that we'd had consumers and carers and involved in every single aspect of decision making. So I think decision making for me it kind of feeds back into that question about what's bad co-design. And I think if you don't have decision making, true shared decision making, it's not good co-design. I think maybe looking at how we evaluate the breadth of co-design, and maybe we need to start looking at some quality indicators for what co-design is. And there's plenty of research out there, I think, at the moment. It's because it is a bit of a buzzword, and I think people are starting to see that co-design is not just a methodology, but it's actually a way, almost like a mindset of how you approach a lot of different things. So the quality indicators that would come to mind would be, you know, have we talked to the right people? Do we have all the right people in the room? Who wasn't in the room? Who did we miss out? What voices did we not touch on? How do we do that better? And I guess I would suggest that you know, it would be good to have co-design evaluated independently in some way.
Have to be.
Yeah, absolutely.
But then I guess also you would need to have maybe another co-design for the co-design, because I know, well,
What? No, I know exactly what you mean.
knowing that I know in some of the meetings that I was in, having the voice of a consumer, a young consumer, and some of the insight that person had, I know, say, for a specific area of the complex. And so we know as someone who, well, I know that person raised the issue, and so that has impacted what was developed and how the process in reality, when there's people using the service, how... So I know that, but then would someone from outside know that was because a consumer said blah, blah, blah? So
Yeah.
Yeah.
And I think that's
Because
really
it's
funny
amazing,
because we did co-design the research element that sits with Jacaranda Place.
Yeah.
So there's a research and evaluation element that looks at the service delivery model. That was co-designed. So yeah, it's complicated, and how long is a piece of string? But I think there probably are some really good quality indicators that we could think about to look back and see whether we've done a good job or not.
Yeah.
I think I see a new consultancy industry growing up.
Yes, perhaps for an
As
organisation.
more and more people talk about co-design,
Yes.
they're going to have to evaluate it
Absolutely.
longitudinally, so it's going to require some expertise.
Absolutely. And we're in the midst at the moment of Queensland Health has funded us to have an independent evaluation done of consumer engagement during COVID, and that independent evaluator has co-designed the evaluation process with the reference group, so there might be some learnings out of that. But,
I could say to Phil, if you need someone for the reflecting on the co-design for the COVID at the PA, our family used the PA quite a few times during that time. So we benefited directly from the ability to smoothly go into the hospital and to have our fear eliminated and things like that. So that's like, oh wow, it worked.
It worked.
It worked.
That's wonderful.
Yeah.
And I guess that's a really nice place to wrap up the conversation. I did want to ask for some brief reflections from all of you. If your projects hadn't been done from this basis of true co-design, how do you think the rollout of those services and those campaigns may have gone? What would have been the dangers of not co-designing?
Can I say one little thing as my final? When I was involved in these co-design projects, to communicate directly with clinicians, for example, and to see their response to some of the things that I've said, and to think, oh, okay, and to notice their response to what I was saying, as in, oh, that's not something that I'd considered. And so then also at the end of some meetings to hear that clinicians say, oh, it was so valuable to have you in the room, you as in consumers and carer representatives. And I hear that again and again, the relief from clinicians to say, oh, I'm so glad, because they're just insights that can't, that can't come any other way, really, because it's seeing the result of all the work that clinicians do. And the other good thing that is the flow on from it, that especially as a carer, I can see the kindness and the dedication that the clinicians have, that really has given me an insight, and I've kind of been able to peek behind closed doors to see what work clinicians, what they do, and how, that kindness and dedication, that it's not all about figures and numbers and, what appointment time and that sort of thing, that, the dedication's amazing, And I wish that more consumers would know that.
I think the professionalism of our... I've probably been a bit rough on clinicians today, and I shouldn't be saying, because they gave me a new kidney, and I will be forever grateful to them. But in the end, they're human beings too. When we were sitting around the table talking about the possible ramifications of not having enough ventilators, and the impact of making that decision about who lives and who dies, and you had some people in tears around a table of seasoned professionals, senior managers who've dealt with things like this, you realise that in the end they are human, and they are in a very human occupation. And the other thing I found with clinicians, and I'll back up exactly what you said, they're looking for ways to do things better. So most of them are. Some are stuck in what the old ways, but many will appreciate any chance to get insight or a new way of thinking, or some validation that it's worth looking for some new way.
Absolutely.
Yeah.
And
it's
it is
not all science and analytical. There's a heart in it, isn't
There's
there?
an art in it.
The heart, yeah,
It's a
and the art.
the
Yeah.
heart and the art.
Yeah.
And both of those things are very human elements that need to be able to be mixed in with the scientific fact and made to be real.
Well, look, that's a beautiful place to finish our session today, the heart and the art. And we hope that you join us next week for our third and fourth final episodes of HCQ TV for more heart and art. Thank you to all of our panellists today, again, for sharing your passion and your learnings from some truly inspirational examples of co-design that are now available through the recording of this program for everyone globally to be able to share. Thank you to our team here at Health Consumers Queensland, at Select AV and at Iceberg for all of your support for yet another successful episode. Thank you to everyone who shared your comments and questions online. Apologies that we couldn't get to all of them, but we really appreciate your engagement and we look forward to welcoming you back again next week. Our next episode is on Tuesday at midday, where we will ask, why do you think I'm hard to reach? We'll hear from consumers about their thoughts on why engagement misses the mark for some groups and what health organisations can do to appropriately engage with a diverse range of consumers. And we'll also hear from staff who lead projects that successfully reach out into communities that really engage with health organisations. So thank you again, and we'll see you then.
Thank you, Melissa.